Hi everyone, I'm just going to get us going right on time, and I'm sure people will still come trickling in. My name is Kara Feldman Hunt. I'm the program manager for UVM Integrative Health. We are the hosts of tonight's program. UVM Integrative Health is a joint initiative among the UVM Medical Center, the UVM College of Nursing and Health Sciences, and the Larner College of Medicine. We have educational programs and clinical programs, and this is part of our Integrative Practitioner Forum. And welcome, everyone. So glad you can be here. A couple of housekeeping items. There is a sign-in sheet, so if you haven't registered and you want to hear more from us, you can sign up out there in the hallway, like in the little vestibule right there. There's also parking passes back there. If you didn't grab a parking pass and you parked in the garage, you can grab one. For providers, we do offer continuing medical education credits. There's a QR code that you can scan with your phone if you want to get credits. It's pretty simple. If you have questions, you can let me know. You can also go on to the UVM Continuing Medical Education website to do that. What else do I want to tell you? We do have some remote sites possibly dialing in. If you are dialing in, please mute your phones so we don't hear you, and you can unmute during the Q&A. Our next forum will be on November 28th with Dr. Chris Chase, who's an anesthesiologist and an acupuncturist. Dr. Chase will be talking about a study that he just published on the geometry of emotions using chakra acupuncture and five-phase theory, try to say that fast, to describe personality archetypes for clinical use. And finally, just to let you know that tonight's talk is really to start opening up the conversation. Kristen's going to talk a little bit more about this. And the views are not necessarily the views of the UVM Medical Center, but really this is an opportunity to open up some doors and hopefully answer some questions. And now I'd like to turn it over to Kristen Cassis, the president of VermontLyme.org.
First, I want to thank Kara for making this event happen tonight. VermontLyme.org is very excited to partner with UVM Integrative Health to bring Dr. Stram here today. VermontLyme.org officially launched in April and is committed to providing effective prevention, education, equitable information, and support to Vermonters affected by Lyme and other tick-borne diseases. Vermont is regularly #1 in the U.S. for incidence of Lyme disease and identified by the CDC as an endemic state. The incidence of Lyme disease in Vermont continues to rise, yet information and access to treatment remains limited. Our audience here tonight is diverse, and I'm sure you all have many topics you would like to discuss and questions you would like to ask. Dr. Stram has a lot to cover in a short period of time, and he's going to give us as much information as he can. And he will take questions at the end, but I'm sure we're not going to get to everything. Dr. Stram has graciously agreed to come back to one of our Lyme support meetings this year, where we can kind of probably get into some more specifics around different topics that relate to those of you that are battling Lyme disease. I know there's many people that have had difficult experiences with diagnosis and treatment, and there are many shared frustrations in the community, but many people are working hard to get us to a different place. I remain hopeful because tonight and nights like tonight are about hope, bringing people together, collaborating, teamwork, coming together as a community to find solutions, to find an easier path to wellness. So I'd like to personally encourage everyone to keep that energy in this room tonight positive, and in that spirit we would ask some of our youngest members who are also working hard to regain their health to say a few words.
We are here to learn and to share. Please speak your truth respectfully and listen to what others have to say.
Different perspectives are good. They help us make progress and consider an array of possibilities.
We welcome passion as it brings fire to the journey. Please channel that energy towards collaboration or solutions.
It would be great if we could all work together on the same team. We all have the same goal, and that's to help people get well.
Let's combine the best from all disciplines of medicine to create and cure and prevent people from getting sick in the first place. One team, one goal. We are all in this together.
Thanks, guys. Super. Okay. Great. So I want to set the stage tonight by expanding the mainstream definition of Lyme disease. Oh. Is that better? Okay. So I just want to expand the definition of Lyme disease. It's not just an infectious disease. As the understanding of Lyme disease continues to evolve, it has become clear that Lyme, Borrelia, and co-infections are not always easy to detect, and for some are not always easy to cure. For the lucky ones, the path to health can be straightforward, but for others who are experiencing persistent symptoms, healing from Lyme requires a multifaceted, functional approach, combining various therapies unique to each individual's body, circumstances, and presentation of the disease. Healing requires that patients, healthcare providers, and caretakers take an active and collaborative role in advocating for their health. Lyme, or Lyme complex, as I like to call it, has become a broadly used term to describe a disease that is more than just an infection of Borrelia. It encompasses a compilation of co-infections that are often perpetuated by environmental factors. Complications may include strains of bacteria, yeast, fungus, mold, viruses, parasites, protozoa, heavy metals, pesticide exposure, etc. Rather than thinking about Lyme as a singular infection caused by a singular event, Lyme, in the broad sense, more accurately describes the cocktail of pathogens and toxins we collect throughout our lives that become opportunistic when our body is not in balance. By expanding the picture of this disease, we now understand that persistent Lyme occurs when our body hits a tipping point of disease pathogenesis, presenting as a variety of progressive, recurring, rotating symptoms, seemingly unrelated to one another. It is possible that someone with so-called Lyme disease doesn't even have an active infection of Borrelia, but a cocktail of other highly pathogenic infections and toxins set in motion by a pathogen-carrying tick or some other triggering event. In the absence of adequate diagnostic testing, the root cause of illness can be elusive. So as you expand your understanding of the evolving definition of Lyme disease, consider that the disease is this: a time and a place when multiple intracellular and blood-borne infections cause widespread system dysbiosis, resulting in serious pathology. A time and place when the overabundance of environmental sludge we harbor, combined with genetic factors, make it difficult for us to detoxify our bodies effectively and efficiently. A time and place when our internal terrain has become overgrown like weeds in a garden, creating a hospitable environment for pathogens to thrive and hide from our immune system. A time and place in which our immune system becomes profoundly altered, triggering a multifactorial process that may affect some or all energetic systems of the body, including the nervous, endocrine, circulatory, respiratory, digestive, skeletal, nervous, muscular, lymphatic systems, and all organs. A time and place in which the downstream effects of this disease make it impossible for our bodies to remain homeostasis. Once homeostasis is lost, systemic dysfunction begins. Specific symptoms resulting in a highly individualized presentation, depending on each person's cocktail of infections, degree of dysbiosis, internal terrain, genetics, stress level, work, and home environments. These variables impact how someone presents with the disease and how they will respond to treatment. Lyme has become a progressive deterioration of the body's functional processes, causing a cascade of events, including mitochondrial dysfunction, oxidative stress, hormonal and methylation dysfunction, neuroinflammation, reduced cellular function, cytokine storms, mast cell disorders, and autoimmune diseases, and the list goes on. It is complex. Restoring health requires a systematic, integrative approach based on each individual's unique situation, an approach that addresses the whole body. This approach requires time and patience, but it can be done. Rebooting the body, the spirit, and the mind. It is about thriving, not just surviving. With us tonight is Dr. Stram, a pioneer in applying integrative medicine to chronic disease, a master rebooter, if you will. Dr. Stram is the founder of the Stram Center for Integrative Medicine. He's a board-certified medical doctor with a focus on integrative and functional medicine. His 25 years of work as a board-certified emergency medicine physician prompted him to recognize the need for holistic and preventative care as a means to reduce the debilitation associated with chronic disease, so often seen too late in the emergency room setting. He felt a strong connection to his original motives for becoming a doctor and decided to expand his career in a new direction by seeking out the Integrative Medicine Fellowship Program at the University of Arizona with Dr. Andrew Whale in 2001. After successfully completing his 2-year fellowship training, he felt committed to providing this form of medicine to his own hometown, which inspired him to establish the Stram Center for Integrative Medicine in 2003. The Stram Center's collaboration between conventionally trained medical doctors with complementary providers is anchored by the respect for all wisdom and science across shared disciplines. More minds working as a team, more minds working together. The Stram Center's integrative approach continues to reinforce his belief that when a medical environment focuses on the social, emotional, physical, and spiritual needs of individuals with chronic health conditions and their support network, healing can occur. It is his experience that this is the kind of health care people are seeking. Every day at the office, he feels privileged to work with his colleagues who share this philosophy, and we are equally privileged to welcome Dr. Stram here tonight.
Well, welcome everyone. Hopefully I can use this microphone, and thank you so much for Kristen for establishing this fantastic organization, which is about support for those that feel lack of it. It's for those that have a voice that felt they didn't have one. And for that, Kristen's tireless energy and the way she put this together is just phenomenal. So I really thank all of you for being here, and hopefully I will shed some light on some of the issues that you all face and the concept of this team management, this leadership amongst all of us, because we are all in this together. This is what humans do. We really try to build a network of people trying to bridge the gap, and that is what this talk is about. It is about bridging the information gap so that, one, that we can prevent this disease from occurring, two, that we can make an understanding of the difficulty in diagnosis, and then trying to get treatment early and broad spectrum. And so with that, I will hopefully continue. See if this works. All right, so introduction. So who am I? So I'll just give you a brief introduction of who I am. I grew up in New York City in the Bronx and went to medical school at Mount Sinai. I started out in general surgery, and after a couple of years of doing that, I decided that I liked the arena of the emergency room. I liked sort of taking chaos and turning it into calm, and I really felt a gravity towards that approach. I also liked acute care medicine, and what I found was that was really resonating with my being. But what I also found that emergency medicine sort of became a revolving door, and I found that I was really just treating chronic conditions that were acutely not being managed by the current health care. So I sought out the fellowship at the University of Arizona, and with that it gave me more of a bag of medicine of which I can treat, and that would be treating with food. Food is the best medicine, or it's your slowest poison, and unfortunately the standard American diet, or SAD diet, is a good acronym because it is a sad diet which tends to cause a number of diseases. And in fact, some of the disease of Lyme disease can be treated very effectively just by changing diet. It is also the understanding that there is a broad range of medical approaches, whether they are traditional Chinese medicine approaches, acupuncture, Tuina, which is an ancient form of massage, nutrition, and really a functional-based nutrition, yoga, meditation, the use of again, herbal-type medicine to see what we can do that has a broad range of activity towards infectious problems. This is really the approach of our office. It is the concept that as a team, as more minds can focus on an individual, the ego becomes left behind, and we can, I believe, really deliver better medicine and better care. So with that, that is my introduction. And what I like to do is I sort of like to reach everything by stories. You know, stories are really what drives us, and it's what really allows us to sort of gain an understanding for sometimes what sounds like a big problem. But when you look at one individual person, you know, the 25-year-old who was a successful MRI tech, and all of a sudden, after she was out hiking with her boyfriend, a few months later started to develop problems with her ability to walk and feel her feet. And yet it was such an unusual symptom, she was really not told anything except maybe it's just she's stressed, it's in her head, and then diagnoses that can be so destabilizing, like MS or ALS, became the prominent form of her diagnosis, which has another emotional impact. And so what I believe is doctor, the word doctor, the root cause, the root word comes from the Latin, docere. Docere actually means to teach, to be learned. So a good teacher is one that continues to learn. Medicine is dynamic. It continues to evolve. When someone says, I already know that, then I would recommend not going to see them, because I don't know. We continue to learn. And that is the active engagement of what medicine offers. And really it is the attempt to try to figure out those problems, what makes it so powerful and such a wonderful field to be in. So the symptoms and treatment, you'll see they are so varied. It is called the great imitator, not because it imitates one disease, but because it imitates many diseases. So what I like to say is that what we have and what we need is resilience. Resilience is what allows us to function within this community while you're still ill. And that resilience is buoyed and ballooned up by the spirit of our friendship and our love, our family, our prayer. That is what drives us. That is what keeps us going. That what maintains our purpose. Lifestyle, and a lifestyle that engages in activity and exercise and movement, and where food is a love that you have towards what you're eating in a meditative way. So veganism, vegetarianism, and we'll talk about diet and some of the actions of diet. And then treatment and your micropathology or your biological terrain is what actually brings you down. Right? That's what can actually make you feel sick. So it is the more power of lifestyle spirit that raises you up. And that is all part of the protocol, all part of the treatment, is to continue in this vein. There you go. Okay, I think I got it. So I'll give you a patient story. This is a young little guy I saw. He was about 9 years old, and he lived in Buffalo, right on Buffalo. And he loved soccer and football and baseball, and he was a really active young boy. And in fact, his older brother was this bodybuilder, so he really looked up to his brother. And all of a sudden, he started to develop these joint pains, and specifically in his knees and his ankles, and he kept on migrating and going all over the place. And so his pediatrician, which reasonable, said, well, it sounds pretty unusual, maybe I should send you to a rheumatologist, and because juvenile rheumatoid arthritis could be a problem. And so he saw this rheumatologist. Now, typically with rheumatological disorders, you have conferring laboratory tests that can confirm the diagnosis, or at least support the diagnosis. And his lab tests were all negative. And he was placed on many different drugs, some of them very strong drugs, what are called DMARDs, or they're biological agents, and sometimes injectable and sometimes painful. The cost of those medications can be upwards of $10,000 a month just to give that type of medication. And what was finding out by his mother and his father was the young boy was becoming more debilitated. His pain was worse. The drugs were not helping. And he was gaining a significant amount of weight. He was, at first when he was 7 years old, he was about 60 pounds. And when I saw him, he was about 120 pounds. And unfortunately, it took the mother, and I will tell you that mothers in general don't mess with them. They typically know when their child is sick, and they typically know that better than any of us in the medical profession. And that is true, and actually the Mayo Clinic did actually a study about that, and mothers were about 95% correct on accurately saying whether a child was sick or not sick. Not their child, but sick or not sick. Pediatricians about 70% and ER docs about 60%. But anyway, I try to listen to mothers just because of that. So he saw several rheumatologists. No one was getting him better. Finally, the mother really demanded that he get tested for tick-borne illness, at least for Lyme disease. And he got tested, and lo and behold, his panel lit up. In fact, he had 10 out of the 10 bands positive on IgG Lyme. And the mother was, thrilled, because all of a sudden now her son had a different disease, until she recognized that it's a little bit more complicated. She went to an infectious disease doctor, and he gave the young boy doxycycline, which is the typical drug that's given for Lyme disease. And he was given that for a month, and he had no improvement. And so then the infectious disease doctor said, well, let's give him intravenous, so through the blood, ceftriaxone, or third-generation cephalosporin, very commonly used in many infections, but typically it also can be used for Lyme disease. The young boy was given that, and he had an acute allergic reaction. And in fact, it was very significant. Nearly died from that medication. And you can imagine, as being an 8.5-year-old young boy, this was a traumatic experience. He was almost had to put a tube down him to help him breathe, and he was very sick from it. They obviously didn't give it to him again, but unfortunately, that was the end of his treatment. The infectious disease doctor said, I don't have anything else to do, and I can't treat him, and so you'll have to go back to your pediatrician. And that's where they found us. And so I was grateful to be able to take care of this young boy. We did treat him. We treated him with an intravenous because he actually couldn't tolerate oral medication. Nothing was actually helping. We treated him with a different drug, which there are different drugs. I think you probably would imagine there's more than 2 antibiotics out there. And he was treated successfully. Now, he was 75% improved. He still has 25% where he still has some chronic pain, of which we are also managing that. But this is just an outline of some of the stories that we hear, and that this is not just a local problem. We are fortunate that some of our patients not only come throughout the country, but they also, this probably doesn't work, right? They also come from across the country. And this was a 35-year-old woman. She was from New Zealand. And she was an otherwise super healthy woman. She typically traveled to France and to Germany, where they would hike, and she was very active. And she started to develop pain. She was a teacher. And she started to develop very severe chest pain. And she was worked up for cardiac problems, for lung problems, and all of her results came back negative. And she was blood tested, and everything came back negative. And the only symptom she had was that she had this really bad chest pain, and she had cognitive problems where she had now poor memory. and she felt that she couldn't remember her lesson plans. She couldn't remember how to get to her local store that she was going for years. She would forget names. She couldn't think of words that would typically be normally that she would be able to think about. And obviously that was very disturbing for her. She was labeled as someone who had a psychiatric problem. And in fact, you know, they said that it was in her head, which I believed it was too. It's just the infection was in her head, and that's what caused some of her problems. She came to our clinic from New Zealand, and she stayed with us for about 6 weeks, and we also gave her pretty active treatment. Now again, when I say what we give is active treatment, we have people do meditation, yoga, acupuncture. We change their diet. We make them actively engaged in their health, because an active participant allows you to feel empowered and not disempowered by the disease. And with this approach, after 6 weeks, she felt 95% better. She was able to go back to her home and then function as a teacher there. And we actually keep in contact through Skype, and she has not been back since. There are other stories which I will probably weave throughout this talk. But now I just want to show you the complications. So I do this on purpose, and the purpose is to show you that this is not a simple disease. It is simple if it's acutely treated. It's not simple when it's not, and it's often missed. It should be on every physician's differential diagnosis, and it shouldn't be something that is left off once you think you've ruled it out. You cannot rule out this disease. We don't have testing that rules it out. So it actually continues to have to come up as a differential diagnosis. And I show this just because this is the Lyme map that we use. We continually assess and reassess symptomatic improvement. We also listen to the beliefs of our patients. So if our patients say, I'm really not comfortable with antibiotics, then we look for other ideas. It's not the limitations of asking the question, it's only the limitation that we have in delivering the answers. So I will go over each of these little parts as we move along this map. So, the typical symptoms of Lyme, and I will tell you there are no typical symptoms. So that's first. But if we would say typical, the first onset of the disease, and let me first give you a little bit of the microbiology. So, first of all, I like to say it's tick-borne illness, because Lyme disease is like, it's like a dirty hypodermic needle when it infects the tick. The tick is like the clown car that says, come on into my body. The tick is a very advanced bug. It is not simple. It's really like an armored vehicle, micro. All of its activity are in its saliva. Its saliva is has very advanced mechanisms. It has in its saliva glue that's kind of like crazy glue. So it doesn't even need to bite you to adhere to you. It also has a local anesthetic, similar to lidocaine that you may get at the dentist. But even better because it's topical. So as soon as it puts its saliva on you, it numbs up the area. It also has a blood thinning agent in its saliva. So not only that it can bite you and open its mouth, the blood thinning ability allows to transfer material very, very easily and very rapidly. So the idea that you need 24 to 48 hours to be infected is false. It's not a fact. It's a fake fact. The fact is that disseminated Lyme disease has been found in case reports of people that have been bit within 2 to 3 hours of having it lodged. So that's misinformation. And that information was from mice. Now, last I looked, we don't look like mice. We don't have hair like mice. And it was done 20 years ago. So the idea that it needs to be on you for 24 to 48 hours is a misnomer. The idea that you don't remember that you were bit by a tick has any relevance. It has none. In fact, if you look at the people that have been diagnosed with Lyme disease, CDC definition of Lyme disease, less than 20% of them ever recall being bit by a tick. So when people actually tell me they were bit by a tick, I think, okay, they must have been bit at least 5 other times. So not only is the tick like an armored vehicle, but its nymph stage is as big as a poppy seed. So you can't see it, you can't feel it, and typically the symptoms don't occur right away. Most common. It is a slow-growing bacteria. It's what's called a stealth bacteria. Stealth, just like a stealth fighter. Unlike other bacteria, let's say strep throat or urinary tract infection. So I'm sure people in this room have had both or either. So typically with a strep throat, first day, your throat hurts a little bit. Second day, it feels like you're swallowing razor blades and you can't even talk. Why? Because the microbiology of beta hemolytic strep is that it grows every 5 to 10 minutes. It doubles in its population. So by doing that, the good news for providers is it's a pretty simple diagnosis. When did it hurt? Yesterday. How much does it hurt now? A lot. Can you open your mouth? Yeah, but it's really hard. Can you talk? I hope I did. Okay, you probably have strep throat. I'll do a culture, I'll do a strep test, and that's pretty good. But that's probably what you have. So, Borrelia, it doesn't do that. It actually grows really slow. It takes its time. It wants to feel out the immune system. It actually wants to evade the immune system. So how it grows is it could be as long as 2 days to double, which means symptoms can occur 2 weeks, 6 weeks, 6 months, maybe even a year. So it's evasive. But that brings me to the most common symptoms. Most common is you can get flu-like symptoms. Now, if you get flu-like symptoms in the summer, that's Lyme disease until proven otherwise. Because you don't get the flu in the summer. It's very unusual. The flu season doesn't really start until mid-October. You get migratory joint pain. Migratory joint pain is Lyme disease, pathognomonic, meaning if you have that, there's not anything else that really causes migratory joint pain except gonorrhea or syphilis. But most of the time, it's Lyme disease. And those two diseases, gonorrhea or syphilis, are very easily treated. And headaches. Typically, a headache is a dull headache. Dull, it just feels like I got some pressure. It feels like someone, took a pump and just put it into my brain and started blowing it up. A pressure headache. The next tier of symptoms, and again, this could be 1 to 2 weeks, 1 to 6 weeks, 6 to 8 weeks. But then after that, that's when the bad stuff starts to happen. Left untreated, that's when the bad stuff starts happening. Now, wait a second. Someone will say, wait. You forgot to mention the bullseye rash. What about the bullseye rash? Oh, I didn't forget. The bullseye rash, first of all, may occur anywhere from 10 to 50% of the time. But it's really specific for Borrelia burgdorferi. which means that if you have another Borrelia infection, and there are many, many strains. Some of them do not give a bullseye rash. Most common, the bullseye rash is misdiagnosed. It's misdiagnosed as ringworm or a spider bite. Now let me tell you, I'm an ER doc, and I work down south. Spider bites, they hurt like hell. There's no mistaking a spider bite. Brown recluse spider bite, it causes a necrosis or a deadening of the tissue, and it's a neurotoxin, so it causes severe pain. Not just, oh, I have this mark here, it's a little itchy. That's not a spider bite. So if anyone says that, just make sure that you go see someone else. Fatigue. 95% of people that I see complain of the fatigue. And fatigue sometimes is actually the most prominent of symptoms. And often people will say, if my house was on fire, I'm not sure I could get up. That's how the fatigue feels. Cognitive dysfunction. It's horrible. Horrible. 29-year-olds that said, I don't know what I'm doing. I was a mathematician and I can't even add 2 plus 2. I don't remember my pet's name when I walk into the room. I can't comprehend simple tasks. I can't remember directions. And I love the ones where, you know, people are seen by a provider and they're 40 years old and the provider says, well, what do you expect? You're getting old. Really? Then what am I doing? I mean, that's like crazy. 40 years old, you're getting old? That's not getting old. And neurological symptoms other than that. Movement disorders, Parkinson's-like symptoms, ALS-type symptoms, multiple sclerosis-like symptoms, and POTS. I know Vermont is a no, that's not the same pod. It's not. It's different. It's different pod. So POTS is postural orthostatic tachycardia syndrome. So what does that mean? It means when you lay down and you get up, your heart starts jumping up to like you just ran a race. So you're laying down, it's like 80. You stand up, it's about 150 or 130. And the definition of POTS is a change in pulse by about 30 points. Shouldn't happen. Very common in young people. Very common in young people that are in their teens, early 20s, and more common in women. Can everyone hear me okay? No. All right. Is that? Got it. Okay. All right. All right. So this is just to show you all the different symptoms that people can have. And if you ask me any one of these, I can tell you that people can have 1, 2, or all of them. So it is called the great imitator. And Lyme is the great imitator. And there have been other diseases that have also been the great imitator. Does anyone know? So syphilis. Syphilis left untreated gives migratory joint pain, rashes, cognitive dysfunction, psychiatric symptoms, cardiac symptoms. Syphilis is a spirochete. It's of the same genus as Borrelia. The difference is there's about 4 times more genes in Borrelia, making it a much more complicated bacteria. Much more. Syphilis, pretty easy to treat. You can actually use single dose, single drug therapy, one time. In fact, 1 shot of Rocephin, you can treat syphilis. So if you look at this, this is the problem. This is the problem because the presentation is so varied. So that's why if it's weird, think Lyme. Think tick-borne illness. Because it's so unusual. You have all these symptoms. One, you feel crazy. And that's the other problem with this disease. Remember we told you it's a stealth bacteria, right? So when it goes out and causes havoc, and your body starts saying, I'm going to fight you, it retreats. It can become dormant. It can hide. Hide in your tissues, hide in your nerves, hide in your heart. And when it does that, you get a rest from your symptoms. You go, wow, I feel pretty good today. Wow, I can actually do stuff. This is great. 3 days later, you get hit again. And then you tell someone that and they go, you sound pretty nuts. You're not nuts. This is the evolution of the disease. It grows typically every 3 to 6 weeks. So it's not uncommon to have these acute respites or acute flares within 3 to 4 weeks. So, for providers here, for people, what do you look for? Unexplained tachycardia. If your heart's beating fast and it shouldn't, think about the cardiac manifestations of Lyme. The things that we worry about, what keeps me up at night, is if I hear it affects your heart or your head. And this isn't a joke. This is a big deal. Cardiac manifestations of Lyme kill people. Myocarditis kills people. Electrical misfiring kills people. Who knows about the athletes that you hear drop dead on the basketball court? Was it some electrical conductivity problem from Lyme? Typically low-grade or mild temperatures. So this is, again, it can vary. Some people get low temperatures. So instead of having a normal temperature of, let's say, 37 or 98.6, you could have a temperature of 97. And you feel cold, you feel chilled. The bug likes that. It likes to grow when you're cold. It grows better. When you heat up, it actually grows worse. Musculoskeletal joint pain. The most common place for Lyme to have its breeding ground is right here, in the occipital tenderness. Very common. People lay down and they go, oh, wow, that really hurts. Very common. Labs, they're typically unremarkable. We get a lot of these labs. We do use specialty labs. I'll tell you, we use labs from everywhere. You know why? Because the testing is terrible. And even from the better testing, it's still terrible. And I'll talk about testing later. Typically, the white blood cell count, which can measure infection, right? People get a blood count and they go, oh, your white count is elevated. You probably have an infection. If it's low, sometimes people say, well, that could be a virus. Well, tick-borne illness, specifically Borrelia, Lyme, lowers the white blood cell count. It is an immune dysregulator. It messes up your immune system. It purposely does that. And then I will tell you, as an ER doc, my background makes me think the worst first. That's just my background. So we get testing. I don't mess around. You got the worst headache of your life? Guess what? You're getting an MRI, CT, you get an LP. I think the worst. You got chest pain, you need an echo, you need an EKG, we got to see what your heart's doing. So we look. And that's important because it can't be taken lightly. So the CDC says Lyme is a clinical diagnosis. Wait, really? I thought the CDC tells you got to get testing. No, actually look on the CDC website. It's a clinical test. It's a clinical diagnosis using laboratory testing to support it. The current testing is a two-tier testing. The problem with the current testing, it's an antibody testing. So we just said, Lyme disease is an immune dysregulator. And let me give you some facts. Facts about testing. There are some scientific superheroes out there. And one of them is named Monica Embers. Monica Embers is she's fabulous. She's an amazing woman too. She's over at Tulane University in New Orleans. She's a primatologist too, which means she studies macaque monkeys. Very closely related to humans. Very closely related on how they get the disease. She's done amazing work, but her most recent work is that she took 10 monkeys and she injected them with the Borrelia bacteria. She injected them in their veins. So there's no question that they weren't infected. 10 monkeys, 10 infections. She waited 3 months, which is not atypical, right? Typically, people come to see their doctor after 2-3 months because that's when the symptoms start. She tested them, and out of 10 monkeys, 10 tests, 3 tested positive, 30%. Now that's pretty bad. That's not even a coin toss. And the one that was the sickest, the most neurologically compromised, the most ill, shaking, not eating, had no antibodies present. None. Didn't raise any antibodies. That's the current testing. Now, they were given 1 month of the only drug, doxycycline. Well, if there is no persistence, if treatment is simple, 1 drug, 1 month, you should be good. They were not. So these monkeys were observed, and the monkeys that had the most neurological symptoms, when autopsy was done after 10 to 12 months, it revealed Borrelia infection in the brain. The monkeys that had cardiac manifestations, Borrelia infection was revealed in the heart. So this is a problematic disease, and the bigger problem is that Monica Embers, before she did this research, was able to get published anywhere. You put your name on a Lyme publication, all of a sudden you can't get yourself published. So this is why you're here, because we, as the public, have to demand that the people that are scientific superheroes can publish in esteemed journals and be representative of this problem. So the testing is indirect. It's an antibody test based on the bacteria. And what I tell people is, you know, what do the bands mean, right? And because hopefully I'll give you some information on that. What do the bands mean? So typically the bacteria is like cut up into 10 different pieces. And some of those pieces are very identifiable for the Borrelia bacteria. Some of them are not. They can be seen with other bacteria. But those that are really identifiable, if you got one of those bands and another band, you probably have Lyme disease. So the current definition is that you need 5 out of 10 of the IgG bands, which are typically the longer term results, or 2 out of the 3 of the IgM bands. Now, the problem with the bands is the IgG bands don't develop until 6 to 12 weeks. When's the best time to get an infection treated? as soon as you know it. The IgM bands, they're not recognized. You don't develop them until maybe 3 to 6 weeks later. And if it's taken 6 months, a year, year and a half for anyone to actually test you, and now all your symptoms are lodged in your joints, in your brain, in your spine, in your gut, it may not even be in your bloodstream anymore, and the antibodies could have dissipated. There are also at least a dozen known strains. There are more. The current lab testing only tests one. It's also, we spoke about that this is tick-borne illness. And ticks don't mind if you got more bugs in their body. And so only testing and treating for one disease means that you've got 4 nails in your foot, and I'm just going to pull out one. Guess what? You don't even think about the one nail that was pulled out. You still got the other 3. So, false negatives, very common. False positives, that's the other narrative. Oh, you were treated? Oh, okay, let me test you. Oh, you're positive still, but you were treated. Well, you're going to be positive because you have antibodies. So the current testing allows for any narrative. Let's say you were treated. Well, antibodies. They could be dead or alive. Doesn't matter. So you're good. No, I'm not good. I don't feel good. I still must have something. Well, now you have post-Lyme treatment syndrome. PTLS, which gives me PTSD. So it's just, it's a crazy thing. It's kind of like saying to someone who has a pneumonia that you treated with one antibiotic and they're still short of breath and they still have a fever, and you say, I'm sorry, you got post-pneumonia syndrome. No, you have persistent symptoms that have not been adequately treated. So, how do we treat? Carefully. No. How do we treat? First, everybody gets treated with their gut first. That's the bottom line. If we don't fix your gut, we don't work the other way. We don't have people that are really sick without treating their gut first, which means that we look at diet specifically. We look at your diet, your behavior. We recommend certain dietary restrictions, which I'll talk about later. But we really use other type of protocols to support you. Craniosacral is a really tremendous therapy that was developed by an osteopath named Upledger, which involves improving flow in the spinal fluid, cranium sacrum. It's a very gentle technique, very helpful for people with cognitive problems and with headaches. Acupuncture, really great for musculoskeletal pain, gut problems, fertility issues. Also, for sinus problems. I mean, acupuncture is phenomenal. And we've used acupuncture in our practice since we opened. Nutrition, like I said, nutrition is part of your treatment. It is paramount. Really, does it make that much of a difference? Oh, so let me give you another story. Hunter, who owned a bar and a restaurant, came into my office. Now, I'll just give you the size. He was about 6'6". I'm not that size, if you didn't notice. And he weighed probably about 300 pounds. And he owned a bar and restaurant in upstate New York. And I said, oh, John, what do you like to eat? He goes, well, for breakfast I have donuts. For lunch I start having a 6-pack. Then I get some pizza. I get some wings, I get some mozzarella sticks, and then I get some fries, and I get a couple burgers. I said, okay, so what do you have for dinner? Oh, well, for dinner, and he went on. And I said, okay, John, first off, you have a lot of exposure. You're a hunter, you got all these symptoms, night sweats, chest pain, joint pain, cognitive problems. He used to work in his own restaurant and do the maintenance, and he couldn't do any of it. Couldn't do it for the past 2 years. I said, okay, John, the first thing is, you know all the food you're eating? You can't eat it. So he literally gets up, looms over my desk and says, like hell, I'm not going to eat that. So the good news was his wife, who is about 4'11", weighed about 80 pounds, grabbed him by the shirt, pulled him up next to her and said, if you don't listen to the doctor, I'm leaving. He just sat down and said, okay, tell me what I got to eat. 6 weeks later, now I didn't treat him, just his gut. Didn't treat him. Just told him about his restrictions, and his wife was on it. He comes in 6 weeks later, his test is positive for Lyme across the board, Bartonella and Babesia. And he comes in, he goes, opens up the door real quiet. He goes, Doc, you're a miracle worker. I said, John, what did I do? He goes, I don't know, but I'm 80% better. Diet. Now that's not typical, but it does happen. So diet is really important. And in fact, if people say to me, I say, well, how are you feeling? And they say, well, you know, I don't feel much better. Okay, then what are you eating? And if they say this is what I'm eating and it's not what we would recommend, we say, okay, then we're going to stop the treatment and you're going to go back to eating what we would recommend. So that's where we start. Now, there are many different herbal protocols out there. They all are somewhat similar in terms of how they use certain herbs. Chinese herbs, the Zhang protocol, very good protocol. Buhner protocol, Cowden protocol, and some of them are very, very effective. Some of them are very complicated too. And so that can be very challenging. But they all have similar type concepts. Cat's claw or cemento in its liquid form, that's from Cowden. That's a very good antimicrobial. It has anti-inflammatory effects. In Western medicine, it was used actually for rheumatoid arthritis. Japanese knotweed, another very good sort of broad spectrum antimicrobial. Andrographis is a phenomenal herb in many of the herbal products that are out there. It's very good for mycoplasma infection besides Lyme. It also has immune stimulatory effects. Artemisia is used very often for Babesia-like symptoms. It also has antimicrobial effects. And in fact, Yu Tu, who is a PhD in China, won the Nobel Prize for her research on how to decoct Artemisia in the fields so that the people that didn't have access to health care were able to treat their malaria by her methods. Amazing. She won it in 2015, the Nobel Prize for Medicine. Grapefruit seed extract, banderol. These are all herbs that, again, if you ask me later, but we'll keep moving on. So, like we said, the food is very important. Your gut microbiota, which if we take the microbiome, your microbiome houses about, and it's hard to say, but somewhere about 50 trillion microbes. Your body has about 1 trillion cells. If you include the microbiota, you change 27,000 genes to 2.7 million. So there's a true belief that if you don't work with your microbiota, then the effectiveness of treatment can be compromised. So I will give you another story. There you go. Poop in a pill. So this is actually a company out of Boston that has now recognized how important the microbiota is. And this is actually true. This is poop in a pill. So have anyone heard of C. diff infections? Okay. C. diff, Clostridium difficile, really nasty bug. When it has virulence factors. When it doesn't, it's not that nasty. So not everything is good and bad. It's just the way it is. Unfortunately, it'd be better, it'd be easier to say, oh, it's all bad, but it's not. So C. diff infections, very difficult when they cause massive diarrhea. Very difficult to eradicate. Has a lot of resistance problems with it. The most common antibiotics are Flagyl or metronidazole and vancomycin. But there's a lot of resistance problems with it. The treatment that is the most effective is fecal transplant. So there are reports that a single fecal transplant to a patient that has resistant C. diff can eradicate the disease. One treatment, 85% of the time. 2 treatments, close to 100%. So what we believe is that if you can change your microbiota, you can alter your health. So, interesting enough, some of the folks that got fecal transplants, so if they were a thin person's transplant, and they were given to a heavy-set person, lo and behold, they started to lose weight. No change in their diet. So remarkably enough, the Danish people, the Danish researchers, did some research, and they took some test studies. 20 men. I don't know why men would prefer to eat poop, but maybe they do. So, and I know some of the wives out there would say, yeah, I would like him to eat. No, but anyway. But they did this, and they took this population that had pre-diabetic, hypertensive, and obesity. They were sort of the Syndrome X type people with high cholesterols, high blood pressure, and borderline diabetes. They tried a 1,500 calorie diet with exercise. And out of those people, after 6 weeks, guess what happened? Nothing. No change. No change in weight. No change in anything. And here it is. They're working so hard. What's going on? The other group, they got a fecal transplant. No change in their diet. No exercise. 6 weeks later, a 15% weight loss. So we believe that the microbiota is so important in the healing of the person. Uh-oh. I need to turn on the, it's muted. There you go. Let me do it. There you go.
I think we actually have to exit out of
Okay.
here. Sorry. Ready?
Ready?
Dietary fiber from foods like fruits, vegetables, nuts, legumes, and whole grains is the best fuel for gut bacteria. When bacteria digest fiber, they produce short-chain fatty acids that nourish the gut barrier, improve immune function, and can help prevent inflammation, which reduces the risk of cancer. And the more fiber you ingest, the more fiber-digesting bacteria colonize your gut. In a recent study, scientists exchanged the regular high-fiber diets of a group of rural South Africans with the high-fat, meat-heavy diets of a group of African Americans. After just 2 weeks on the high-fat, low-fiber, Western-style diet, The rural African group showed increased inflammation of the colon as well as a decrease of butyrate. That's a short-chain fatty acid thought to lower risk of colon cancer. Meanwhile, the group that switched to a high-fiber, low-fat diet had the opposite result. So what goes wrong with our gut bacteria when we eat low-fiber processed foods? Lower fiber means less fuel for the gut bacteria, essentially starving them until they die off. This results in less diversity and hungry bacteria. In fact, some can even start to feed on the mucus lining. We also know that specific foods can affect gut bacteria. In one recent microbiome study, scientists found that fruits, vegetables, tea, coffee, red wine, and dark chocolate were correlated with increased bacterial diversity. These foods contain polyphenols, which are naturally occurring antioxidant compounds. On the other hand, foods high in dairy fat, like whole milk, and sugar-sweetened sodas were correlated with decreased diversity.
All right. So I think that's better. That's easier. So really, like we were saying, one of the most important parts of our treatment involves the gut first. So often people don't recognize that actually your neurotransmitters, dopamine, serotonin, 70% of it is production starts in the gut. Your immune function, your antibody production, 70% of them start in the gut, Pyrus patches. So not addressing the gut and its effect is really significant. And I will tell you, even as an ER doc, whenever I gave antibiotics, I made sure people took a specified probiotics. Because again, if you're thinking about antibiotics as pesticides, then probiotics are fertilizers. And how do you ruin a good field? You just give pesticides. And so they should always go together. Not together, but one should be taken separately from the other. Typically, we recommend taking probiotics in the morning and in the evening, and any of the antimicrobials, whether they're herbs or antibiotics, sometime during lunch or dinner times. So sometimes it's easier to go the other way to get the probiotics in. And so with some people that have very difficult times digesting, or that the probiotics actually get destroyed in the gastric lining from the acid secretion, we recommend probiotic enemas. It is kind of the concept of fecal transplants. And typically that amount is a very high amount of bacteria. We often use soil-based bacteria that do not have a number count to it. They're not in the billions. They're actually just a soil-based, it's kind of like eating poop, but it's soil-based bacteria. And then the other would be using some form of probiotics, typically diverse. So we typically have people use 2 or 3 different types of probiotics from different companies so that you have more diverse flora. Because as you saw from the video, the more diverse your flora is, the healthier you are. So what do I eat? So typically what we tell people, and this is typical, is the most common allergens that we see when we test. And we do often test food allergies. And we don't do the common food allergy, which is an IgE response. And IgE is one of the antibodies that's an immediate sensitivity reaction, meaning it's the kid in the class that has a peanut and has a significant allergy. That's an immediate sensitivity reaction. That is an IgE response. It's typically histamine related because it's the mast cell, which is part of the white blood cell armamentarium, that produces IgE antibodies and histamine. And histamine is the stuff that gives you the the sneezy nose and the red skin, and it inflames. And it causes a congestion. And why does it do that? Because it wants to localize the symptoms. It's actually good for you on some level. But when it's overwhelming, it's not good for you. But that is what we typically don't use, because most people know what they're allergic to when it comes to food. So you know if you have a peanut allergy. You know if you've had some kind of acute response. So we typically look for more of the long-term responses, which are mostly IgG or IgA responses. IgA, just think of as an acute response. Typically within a week or so you can have symptoms from it. IgG, like we said, can be 6 to 8 weeks later. And so what we do is look at what's the most common allergens. Most common that we see, dairy. Dairy is probably number 1. And unfortunately, eggs are number 2. So I know eggs are typically seen as a really good food, healthy, and they could be, but there are often a number of people that have allergic responses to eggs. The other is wheat and certain nuts, and the most common is almond, and it's probably because of such an increase in the amount of people eating almonds. What to eat? Ketogenic, paleo, anti-inflammatory. We have our nutritionist is a functional nutritionist. She's been in the field for 30 years. She has training from the International Functional Medicine. It took her 6 years to get this training. She's able to kind of figure it out, because this is complicated. And I will tell you that out of every appointment, the most questions I get is about diet. What do I eat? How do I eat it? What am I going to eat? I can't even eat breakfast now. You just told me I can't have eggs. I can't have toast. But what do I eat? So that's where we work with her, and this is just sort of the range that it can go. So this is just giving you, this is data. This is data showing that low-fat, vegan diets in someone who is diagnosed with rheumatoid arthritis has a significant reduction in symptoms. A vegan diet free of gluten improves the signs of rheumatoid arthritis and reduces antibody levels. So some of the lab testing will go down as well. So now, okay, we got all this stuff. You're going to treat me, but how do I balance the toxicity of treatment versus trying to kill the bugs? And that is the fine line. And that is the line that we say really needs to be managed appropriately. Because antibiotics are like chemotherapy in some ways. They can really make people sick, and they have to be used very judiciously. So we typically use supplements, or again, foods that improve the detoxification pathways. So cruciferous vegetables, one of my favorite foods to talk about, have something in it called calcium deglucarate, which helps to manage detoxification and elimination out of your gut. It helps what's called the phase 2 pathway of detoxification. Turmeric, curcumin, very good in stimulating the phase 2 detoxification and reducing or slowing down the phase 1. Because phase 1 is basically, we just got to make it look less like fat and get it into your bloodstream. But if you do it too fast, you can overwhelm the system. So turmeric really can help in reducing that. So it is a balancing act. So sources of toxins and toxicants, and Kristen mentioned it, that we unfortunately have a lot of exposure. We have exposure to pesticides, man-made toxins, whether it's the rugs in the building or the air or the food that's processed, pharmaceuticals, the bacteria that die off during treatment. And then what we use is supplementation, which can really help. Supplements such as glutathione. Glutathione is an amazing tripeptide. It is the body's most common and versatile detoxifying supplement. It's a 3-peptide, 3-amino acid peptide, and it is the most commonly used for detoxifying drugs. We support it. You can give it either IV, which is the most effective, and there are some liposomal or fat-type forms of glutathione which can activate in the body. There's N-acetylcysteine, or NAC. N-acetylcysteine, and any of you nursing people out there, you may know N-acetylcysteine. NAC was used in the hospitals to actually decrease mucus. It was nebulized so that it would decrease mucus production when people would have asthma attacks or respiratory problems. NAC is the antidote for the most common cause of liver failure. What's the most common cause of liver failure? Go ahead. Tylenol. Acetaminophen. In a bottle. Take 1 bottle, you're done. 2 days, your liver dies. NAC is the antidote. If you give it within 6 to 8 hours, 6 to 10 hours, we used to give it orally. It smells terrible. Imagine, it smells like sulfur. We now give it IV, and it's very effective, and it basically reverses Tylenol toxicity. Amazing amino acid. Chlorophyll, which acts as what's called chelating agents, which bind. Cilantrogen, charcoal, all these binding supplements. Infrared sauna, really effective in helping to detoxify. Low light therapy, which is a focused use of infrared therapy. Hyperbaric oxygen therapy. Hydration and physical activity. Vitamin C is a pretty remarkable vitamin. We use it we use it a lot in our office. We use it both in its oral form. In its oral form, it's an antioxidant. It's involved in tyrosine metabolism. Tyrosine is one of the cofactors for thyroid functioning. It's a cofactor in the synthesis of thyroxine, carnitine, which helps to transport proteins, norepinephrine, dopamine, and tryptophan, which are, again, the neurotransmitters. It is involved in oxidation reduction reactions, respiratory, carbohydrate metabolism, synthesis of lipids, catabolism, breakdown of cholesterol, bile acids. And it's a very difficult vitamin in terms of how do you recognize it when people are deficient. The most common is people get personality changes, they get decline in psychomotor performance, and motivation. And this can occur within 3 months of having poor diet. You look at some of the communities which are called desert food communities, where the access to the great food that you have in this area is limited. These people likely have some form of vitamin C deficiency. So really interesting. We use vitamin C in its IV form. So its intravenous form, vitamin C turns into a pro-oxidant. So pro-oxidant is like a chemotherapy drug. But the really interesting part is that your body actually recognizes it at something that's normal and healthy. But certain other factors, like bacteria, do not have the necessary enzymes to break down the peroxide radicals that occur from high-dose vitamin C. They actually lack the enzyme called catalase. And by lacking that enzyme, you can actually focus on actually eradicating or improving eradication of the bacteria, and specifically also some viruses. And we've seen it effective for some of the herpes viruses, specifically for Epstein-Barr virus. This is a study that's being done using high-dose vitamin C in sepsis patients. And what they're finding is it reduces this chemical called thrombomodulin, which is this sticky substance that gets stuck in all the organs and essentially causes multiple organ failure, which is what sepsis does. and is what causes the death in most people. And it has a significant decrease in thrombomodulin, and then can improve and reduce the vascular endothelial inside tissue injury. So now we're back to the map. So here's where you enter. We look to see what we can do for you. We tried different antibiotics, and just to give you an idea, doxycycline, first-line drug. It's also the highest number of bacteria that turn to dormant form when given. In fact, Dr. Zhang out of Baltimore, out of Johns Hopkins, he's done research looking at the different drugs. Doxycycline and amoxicillin are the most prominent in forming dormant or persistent cells. So 90% of it will kill. The problem is the other 10%.